Hi, everyone, and welcome to today's Journal Club. I would like to thank, of course, ESGO and IGCS for their support in our Journal Club. Before we begin, I just want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the discussion will be made publicly available. The participants with cameras turned on may appear in the video recording. And we ask that everyone please keep your microphones muted so everyone can hear the presentation. If you're having any difficulties or questions, please send a message in the chat and our technical support system will assist. We will have time definitely for questions, and we definitely encourage everyone who has joined to please submit your questions through the chat. We always love to see this engagement and interaction from our audience. So this month's lead article is the Seneca study, staging endometrial cancer based on molecular classification. Lead author is my dear friend and colleague, and also former fellow of this International Journal of Gynecological Cancer, Enrique Chacon, who is at the University of Navarra. And we really are very, very excited to discuss this article. It's great to see you, Kike. Thank you so much again for submitting your work and your article to our journal. And once again, welcome and thank you.
Hello, everyone, and thank you, Pedro, for your words, and thank you to the journal for selecting our article as lead article. It is a real pleasure and an honor to be here today discussing about our article, the Seneca study, staging endometrial cancer based on molecular classification. Before we start, I would like to introduce the different members of the Seneca Scientific Committee, Dr. Felix Boria, who is here with us, Dr. Luisa Sanchez Lorenzo, and of course, Professor Luis Chiva, because I am pretty sure that it will be a real pleasure to listen to their comments during the discussion. So now, here we go. Could you see my slides?
Yes.
Okay. So, well, the Seneca study is an international and multi-center study that retrospectively collected data from 2,258 patients across 66 centers spanning 16 different countries. Our primary objective was to assess the sentinel lymph node involvement rate according to the molecular subtypes in patients with stage 1 and 2 endometrial cancer. Secondly, we aim to evaluate the accuracy of the new ESGO prognostic risk classification for the prediction of sentinel lymph node involvement with respect to the classical risk classification based only on histopathological factor, and the first one including molecular profile. To achieve this, data were collected from 2,215 patients, and after applying inclusion and exclusion criteria, we arrived at a final sample size of 2,139 patients. So here you have the main picture of our multi-center international retrospective observational cohort study comprising 2,139 patients with stage 1 and 2 endometrial cancer that underwent a standard surgical protocol according to ESGO guidelines, including total hysterectomy together with SLN algorithm between January 2021 and December 2022. Patients were categorized according to the molecular subtypes in 4 groups: poly-ultramutated, mismatch repair deficient, non-specific molecular profile, and P53 abnormal. And again, our primary objective was to evaluate whether there were significant differences in sentinel lymph node involvement for each of the molecular subtypes. And we arrived at the results. With regard to the molecular profiling, this was predominantly tested in the final pathology, and a complete molecular profile was obtained in 57% of the cases, while in 43% of them, poly-ultramutated analysis was omitted due to low risk or intermediate risk histologies. Concerning the distribution of the groups, the two most prevalent groups were non-specific molecular profile in 56% of the cases and mismatch repair deficient in 27% of the cases, followed by P53 abnormal in 12% of the cases. The lowest prevalent groups was poly-ultramutated with less than almost 5% of the cases. Focusing on the SLN approach, we identified a total median number of 2 sentinel lymph node per patient, and for us, it is very interesting to highlight that a tracer diffusion in at least one site was identified in 97% of the cases, with a bilateral tracer diffusion in more than 81% of the cases. By ultrastaging or OSNA, we identified 205 patients with affected sentinel lymph node, representing around the 10% of the sample. Of these, around the 70% of these had low volume metastases, including ITCs and micromets. Among these 205 patients with affected sentinel lymph node, if you remember, our primary objective was to determine whether there were significant differences in sentinel lymph node involvement according to the molecular subtypes in patients with stage 1 and 2 endometrial cancer. And what we observed is that there were significant differences with the two groups, P53 abnormal and mismatch repair deficient, being the two groups with the highest rate of nodal involvement, 12.50% and 12.40% respectively. You know, this 1.6 higher chance of these two groups to have positive sentinel lymph node may be influenced by the higher rate of deep myometrial invasion within the group of mismatch repair deficient, or by the greater prevalence of non-endometrioid high-grade positive LBSI status tumors within the group of P53 abnormal. Secondly, we aim to evaluate the sentinel lymph node involvement rate for each of the ESGO prognostic risk groups. To accomplish this, patients were categorized according to the new ESGO prognostic risk classification, which takes into account the final pathology, the final FIGO stage, and the final molecular profile. And again, we observed significant differences with a sentinel lymph node involvement rate of 2.80% for low-risk patients, 6.60% for intermediate-risk patients, 21.60% for high-intermediate, and 22.50% for high-risk patients. Subsequently, we sought to determine whether the molecular profile improved the prediction of nodal status when compared to the classical risk factor. And what we observed is that there were no significant differences. In other words, molecular profile did not improve the prediction of nodal status when compared to the classical risk factor, since the rate of nodal involvement remained very similar between the different subgroups without significant differences in the area under the curve for the two models. So in summary, we can conclude that our study reveals significant differences in sentinel lymph node involvement according to the molecular subtypes in patients with stage 1 and 2 endometrial cancer. And of course, we have defined for the first time the rate of sentinel lymph node involvement for each of the ESGO prognostic risk group. And in this sense, for us, it is very interesting to note that molecular classification did not improve the prediction of nodal status when compared to the classical risk factor. So for us, and for all these reasons, lymph node staging, we consider, should not yet be adopted based on molecular profilings, since prospective studies are needed to validate whether these significant differences may impact on survival. Before we finish, I would like, of course, to express my sincere thanks to all the participating centers, because, you know, without them, this study wouldn't have been possible. Thank you.
Okay, thank you so much for that presentation. And again, congratulations for bringing together so many centers. We all know how difficult that is. So congratulations to you and everyone. I think before we start with the questions from the fellows and then also from the audience, a very key and important question that I think a lot of people have in their minds is, what does Seneca stand for?
Yes, you know, the main reason for designing this study was because when we talk about molecular classification in endometrial cancer, we are really talking about a new era in the natural history of this disease. During the last few years, Pedro, there has been a great change in the knowledge of this disease, moving from the description of the two main histological subtypes at the beginning of the 80s to the definition of these new molecular subtypes in 2013, thanks to the studies carried out by TCGA project. And of course, we know, thanks to Alicia Leon Castillo, that there are significant differences in treatment responses and also from prognosis between the different subgroups. But taking this in mind and considering that also during the last few years there has also changed a lot the management, the surgical staging of endometrial cancer, turning in early disease confined to the uterus, staging 1 and 2 endometrial cancer, from a pelvic or para-aortic lymphadenectomy, depending on the risk group, to a generalization of the sentinel lymph node algorithm with an excellent performance, as you well know. Our question was, do we have today enough evidence to integrate the molecular classification into the SLN algorithm? And this is how the Seneca study was born.
So what does Seneca stand for? What is the word Seneca?
Ah, okay. Sorry, I did not understand your question. Sorry.
No. I'm glad you gave that answer
This
because
was
it was a
the
very
rationale.
thorough answer.
But this is also a very interesting point, Pedro. Because Seneca comes from Lucio and Neo Seneca, who hailed from Cordoba, the southern Spanish city where I was also born. And Seneca is one of the father of Stoicism, a philosophical doctrine that encourages the pursuit of knowledge even in the face of adversity. So this also, Pedro, was precisely the main aspiration behind our study.
Excellent. Well, thank you so much for that. And we're going to start with some of the questions from our fellows. And the first one is Jose Carlos Vilches from Malaga. Jose.
Thank you, Kike, for your amazing presentation. Okay, I will ask. I want to ask you. There is an incomplete molecular profile without pol E in 40% of the cases due to the presence of low risk or intermediate histologies. How do you handle this patient in your hospital? How do you recommend testing everyone? When should perform the testing? After the curettage or after the hysterectomy?
Thank you, Jose, for your question, and thank you, obviously, as Pedro said before, for your hospitality during the last ERAS Congress. First of all, I think it is very interesting to note that our study is a real-life study, and as such, reflects the reality of our clinical practice in more than 60 centers worldwide. Currently, the trend is not to analyze poly in low-risk or intermediate-risk histologies, and this is probably due to the cost involved and the low impact on decision-making. Our hospital is, a private as yours, an academic hospital, and for us, the cost balance is very important. That's why we don't analyze the poly, low, and intermediate risk patients, since nothing for us is going to change depending on the results. Finally, regarding when to analyze the molecular profile, if you perform it, for us, we do it in the preoperative sample, only for P53 mismatch repair in cases of low and intermediate risk, since the correlation with the final pathology is very good, and we think that the more information we have, the easier it will be to make decision in future.
And Kike, as a follow-up question to that, generally in Spain, is a molecular classification available in most centers?
Yes, this is very interesting. We carry out a survey last year in the context of a study carried out by MSD. And we think that it is a reality, but far away it's not a reality. Is in the big hospital, in the big centers, of course, mostly are carrying out the molecular analysis. But today there is still a need in low and middle centers to perform the molecular profile. Yes.
And then also as a follow-up question to that, given that that obviously now molecular classification is part of the new staging, and with no consistent availability of that molecular profiling, in your institution, are you using still the previous staging or the current FIGO staging for endometrial cancer?
This is a hot topic, Pedro. Yes, we are definitely using the previous staging, the 2009 staging, and we are basing our decision on the FIGO stage. But the unique difference is in the final report, in the final pathological report, the pathology are incorporating this new FIGO staging. We are just reporting both of them, just in terms of information. But we are follow our recommendation based on the last on the previous FIGO staging, and of course in ESCO guidelines.
Excellent.
Because this is just my humble opinion, but it's very tricky to understand and to know this new classification. A lot of variables and a lot of substages, and it's quite tricky.
Excellent. All right. Well, and again, I want to encourage any questions from the audience, and I'm sure, of course, obviously, Kike would love to welcome those questions as well. The next question is really also an interesting topic with the discussion, as we today are looking at sentinel lymph node versus lymphadenectomy. So Roberta Masobrio will ask your next question.
Thank you for this summary. And as we know, the concept of lymph node biopsy in endometrial cancer was introduced before the implementation of molecular classification. Now, international guidelines have supported this approach due to its sensitivity for nodal staging and the lack of therapeutic approach from pelvic lymphadenectomy. With the advent of molecular classification, do you believe there might be a renewed role for full pelvic lymphadenectomy, especially in high-risk patients?
Okay, grazie mille, Roberta, for the question. I strongly believe in the sentinel lymph node algorithm, as it has been shown in prospective studies to have an excellent performance even in the setting of high-risk patients. In this sense, I think it is very important to emphasize that for the sentinel lymph node technique to be correct, we must start with a very good injection of the tracer. For us, this is the most important point. We have an amazing ENIGO webinar. You can take a look. It's amazing how the technique is completely explained. And we explain how we inject very carefully the ICG slowly, very slowly into the cervix at 3 and 9 o'clock. And then we proceed with a correct dissection of the avascular spaces of the pelvis, identifying the direction of the tracer, and resecting the first node into which the tumor drains, which is mainly the concept at the end of the sentinel lymph node. This is very important, also very important message, very crucial. Please don't take out the first green node that you find in the pelvis. I really think that if we are very methodic and if we do by this way, the performance will be excellent in all patients, including high-risk patients. And finally, regarding the role of molecular profiling in the prediction of nodal involvement, as we have seen in our study and also in the PROM trial, our recently published prospective trial, also an international journal, it seems that molecular profile does not improve per se the prediction of nodal involvement when compared, as we said during my presentation, to the classical histopathological factors.
Okay, thank you.
Excellent. So, Kiko, we have a question from the audience. Dipali Raina is asking, are there any existing or potential markers for risk substratification of the NSMP group, the non-specific molecular profiling group?
Yes, this is a very good question. I don't know, Luisa, are you here? I could reply without any problem.
Hi, hello.
Hello, Luisa. Let me introduce Luisa. Luisa is our medical oncologist. She's the most clever woman in our hospital, and we discussed a lot about the different subgroups in this non-specific molecular subtypes, especially in the setting of hormone receptor. I don't know if you got out something interesting for this question, Luisa.
I think that we will have to describe two different groups in the NSMP. You described the hormonal receptors. I think in the future we'll have to reanalyze the data of all the trials that we are carrying out right now in first line, because my point of view, my humble point of view, we'll see many difference, and the magnitude of benefit in the NSMP will be different according to the hormonal receptor expression in those tumors. And probably in the future we'll have to make like different clusters within that group. That is what I think.
Excellent. So we will proceed with our next question from our fellow Raikan Bolatbekova.
Thank you. Thank you. I have a question. Do you think that if the molecular profile were performed in all patients preoperatively in the biopsy with these data and the preoperative imaging data, the sentinel node could be omitted in some cases, mainly with the objective of omitting pelvic lymphadenectomy if the sentinel node technique fails?
Thank you, Raikan, for this amazing question. Yes, again, this is a hot topic. In terms of preoperative staging, if you think a little bit, the rationale for this study was that we, as surgeons, we tend to stage patients with endometrial cancer based on imaging and also about the information provided by the biopsy. This usually gives us the radiological stage of the disease as well as the grade and the histology. It is rare, as we said before, in Spain at least, to have in the preoperative biopsy the molecular profile, and it is even rarer to have the LBSI status. So in this scenario, if you imagine, we may have a patient who apparently has a stage 1 by ultrasound, which with the biopsy that tells us it is an endometrioid tumor. So now let's imagine that this patient is obese and therefore difficult to be operating on. So if the tracer doesn't diffuse in this situation, with the data we have, anyone can say, look, I am tired, it is low-risk patient, and therefore I am not performing the pelvic lymphadenectomy. But what happens if the imaging fails and she had deep infiltration of the myometrium and she was also p53 abnormal, and therefore she has a high risk of lymph node involvement? Well, I think, and I told that also in the podcast, this is one of the things that the Seneca study has highlighted, how interesting it is to have the preoperative molecular profile, at least p53 and mismatch repair, which are mainly the group at high risk, so that we can classify our patients more accurately and thus tailor better the surgery. This has also been observed in a recently published article called by Silvia Cabrera from Barcelona, Spain, in which she points out that molecular classification improves the prediction and the preoperative risk assessment of patients with endometrial cancer. However, as you said before, as for omitting pelvic lymphadenectomy based on molecular profile in cases of tracer non-diffusion, my opinion is definitely no. Lymph node staging should not be adopted based on molecular profiling, since it is still too soon and we are still learning. This is very important. And for me, it seems that the classical histological factors weight more and predict better. This is also key, the nodal status than the molecular profile. Don't forget, if you take a look on our tables, that in our cohort, there are a 6% of poly patients with affected sentinel lymph nodes.
Excellent. Kike, thank you so much. Just like to let you know, we have 54 participants in the Journal Club, so obviously lots of interest in the Seneca study. Next question comes from one of our former fellows, also from Italy, Giuseppe Cucinella. Giuseppe, do you want to ask your own question? It's great to see you, Giuseppe. We missed
Hi everyone. Congratulations, Enrique, and I mean, you already answered to this question. Just to be more precise, doing just an example, if you have a figure 1 low grade on the preoperative imaging, and then you have no mapping, and maybe we can apply the Mayo criteria, and we have low risk, so below 2 centimeters, no infiltration and low grade. At this point, we have to decide what to do. And that, for instance, if the molecular profile is a p53 abnormal, now we have some risk to have lymphadenectomy, positive lymph node based on Seneca study and also the study from Canada. And as you said, today we are a little bit far from the real data to decision. And then the question I said, maybe we have to wait the eugenic trial. But I mean, what's your feeling when you have this situation? It's rare, but what's your feeling? Are you pro doing something more in terms of staging or not? And what's your, I mean, your policy in your institution for sure? I can say that in our institution, I think in Italy, we don't do staging based on the molecular profile, but the data are coming out and maybe there is something that can push us to do more aggressive or not. Thank you, and congratulations.
Grazie mille, amico. Look, we are just following the SLM algorithm, and if we are in the middle of the surgery and with the information we have, we consider this patient is a low risk, then we are not performing even more the pelvic lymphadenectomy. But of course, I think one of the things that the Seneca study has had is we have defined the rate of sentinel lymph node involvement for each of the ESGO prognostic risk group. If you remember the table, 2.80 for low risk, 6 for intermediate risk, and then 21 and more than 22 for high risk patients. So at the end, one of the things is when the guidelines says, and this is very important to follow the SLM algorithm, but of course, and I think this was trying to ask, is there are some gray situation in which you have to act with the information you have. And I think it's very important to have in mind this table with the different percentage of sentinel lymph node involvement for the different subgroups, because this could be very useful for the decision making in theater, this percentage.
Excellent. Very well. Now we'll go to Turkey. Mine.
Okay, sorry. Hello from Turkey. Enrique, it's great to see you and great to see Professor Shiva again. My question is on the rate of lymph node involvement in P53 abnormal subgroup. How do you explain the low rate of lymph node involvement, which is about 12% in P53 abnormal group in Seneca study, despite performing sentinel lymph node biopsy, which enhances the detection rate of low volume disease and classifying isolated tumor cells as nodal disease. Previous studies have reported lymph node involvement rates around 20 to 45%. What do you think could have contributed to this result?
Thank you very much, Mine, for this question, because it's very clever. Look, the reason is simple. Patients with abnormal P53 can be grouped into two categories: those at intermediate risk, which are those mainly patients with a stage 1A without myometrial infiltration, whose risk of lymph node involvement in our cohort is less than 7%, and those at high risk, which are mainly the rest, and who have a risk of lymph node involvement in our table, in our cohort, of around 22%. So in our study, the overall risk for P53 abnormal patients, as you mentioned before, was around 12.50%, possibly because there is a higher proportion of intermediate risk patients with P53 abnormal than the higher risk ones. I think this is the main reason.
Excellent. Very well, Kike. And now we have another question from the audience. This one is a very interesting paper. In the discussion, you mentioned that there was a higher incidence of positive sentinel lymph nodes in the MMR deficient and P53 abnormal due to higher incidence of myometrial invasion. Was there a significant difference in the incidence of myometrial invasion between MMR deficient and P53 from the other groups?
Yes, could you please repeat, because the last part of the question I was not able to understand?
Yes, so was there a significant difference in the incidence of myometrial invasion between these two groups, the MMR deficient and the P53 abnormal?
Yes, definitely. The group with the highest rate of deep myometrial invasion was mismatch repair deficient. And this was also observed in the final analysis of the PROMISE trial. If you take a careful look of the tables, this is the same trend. Patients from mismatch repair deficient had higher rate of deep myometrial invasions, and patients from P53 abnormal group had higher rate of non-endometrioid high grade and positive LVSI status. I think this is just the natural history of this disease with regards to this subgroup.
Okay. Another quick question from the
excuse me. Yeah, I'm Albert. I asked the question in the chat box.
Oh,
what
yeah,
I
Albert,
actually wanted to, what I actually wanted to ask is whether there was a significant difference between MMRD and P53 compared to the other groups, NSMP and poll-mutated.
Yes, definitely. Yes, definitely. This differences was in comparison to the other groups.
I just wanted to clarify that. Thank you.
All right. Sorry, Albert, I'd misquoted your question. So next question is, in this study, the ITCs are accepted as positive sentinel lymph nodes. How did the authors think about isolated tumor cells because of their acceptance as N1 is not fully accepted in the literature?
Yes, this is again a very interesting question. We are fully agree, and this is also highlighted in the discussion of our manuscript, that ITC is not considered also in our manuscript P positive nodes. Okay, this is very, very important. But of course, our study was a nodes study, a sentinel lymph node study, and for us was very interesting to know, to understand the reality of these differences between the different molecular subtypes also in this setting of ITC, especially in our day where we are always pushing our colleagues just to implement the ultra staging or the OSNA, and if we implement this procedure, we are going to have higher rate of ITC. So I think we should know and we should understand this subgroup of patients with ITCs. And of course, we should know how to manage it. We are very lucky to have here Giuseppe Cucinella. I think he is working a lot of this field. And of course, I encourage the person who asked to contact Giuseppe because he's amazing in this setting of ITCs.
Excellent. So we'll go back now to actually Spain. Elena.
Hi, congratulations for the study and great presentation. My question is related to a recent study led by Professor Persson, where they described 2% of isolated metastases in parauterine lymphatic tissue. So based on the result and the results of the Seneca trial, the question is if you would consider to remove this tissue in patients with P53 mutated endometrial carcinoma.
Thank you, Elena, for this difficult question. You know, Jan Persson is one of the greatest.
First, it's like, what is the parauterine lymphatic tissue?
Yes, it's like you have to understand. It's quite difficult. But yes, there is a very interesting article just published from Jan Persson. I think I encourage all to take a look. And we all know Jan Persson is one of the greatest experts in endometrial cancer. We have all followed him closely, and of course, we have to respect his opinion and take it into account. I am very aware of this recently published, as I said before, which states, if you take a look in the conclusion, that the obturator fossa is the predominant site of metastatic disease. Therefore, they argue that a selective removal of lymph node is in these typical proximal obturator fossa and interiliac positions, and of course of this so-called parauterine lymphovascular tissue, which is mainly the tissue close to the paracervix, like when we perform a parametrectomy in cervical cancer, can replace a specific full-site pelvic lymphadenectomy when sentinel lymph node mapping is unsuccessful. I think, again, this is very interesting, especially in the setting of obese patients, in order to reduce the morbidity, to de-escalate the radicality of the surgery. But again, in patients where we have a good diffusion of the tracer and we have followed the step-by-step of sentinel lymph node biopsy, I think removing the sentinel lymph node is more than enough.
Very well. Kike, we'll go back now to one of your former colleagues in the fellowship. Nico Bizzarri, great to see you.
Thank you. Thank you. I'm so happy to see Kike here, and I feel really part of this journal club. Thank you, Kike, and thank you, Pedro, for arranging. So I've just got a question. Congratulations again to Kike and all the team, Luis. So after conducting this study, would you still recommend Sentinel for all patients with endometrial cancer, even if molecular status was known preoperatively? In other words, would you still do Sentinel both in poly and in P53 abnormal if you known preoperatively? At the end of the day, we do the same for all.
Yes, definitely. Nothing has changed. Yes, we wrote that in the discussion. Today, molecular classification and lymph node staging should not yet be adopted on the molecular profile. And yes, Nico, I am fully agree with you. I understand that there could be some special settings, especially in high-risk patients. Your group has published some time ago a meta-analysis saying that there could be potentially a potential benefit in terms of prognostic for para-aortic lymphadenectomy in high-risk patients. But yes, we definitely are following the SLN algorithm for every patient.
Very
Thank
well.
you.
Excellent. Nico, great to see you. Thank you for joining as well.
Thank you.
So now we come back to the United States. Ali from Salt Lake City.
Congratulations on your study. It was a wonderful presentation. This is kind of a follow-up to, I guess, the last question. Given that the molecular analysis was predominantly performed on postoperative specimens, do you believe that performing the molecular analysis preoperatively would be more beneficial for surgical planning? And if so, how might this change the approach to treatment or staging for endometrial cancer?
Okay. Felix, you are also here, and if you want to ask something, feel free.
No, you're doing
for
great,
this tricky
Enrique.
question.
You're doing great.
You're allowed to
No,
phone a friend.
One thing, it's most of the biopsies, most of the molecular analysis were made on the post-operative samples. So I think that we may not know if this would be the same if we have done in all the samples pre-operatively, you know, but I don't know if we can answer that question, you know.
Yes, the message here, the key message is, if you are decided to perform molecular analysis, I think it's going to be more useful if you perform it preoperatively, because you are going to have more data, more information, and the more information you have, the more accurately you are going to stage your patient. I think this is my humble opinion.
Yeah, for sure.
And of course, Professor Luis Chiva, if you want to add something.
Well, I mean, I completely agree with you. I mean, the capacity of learning in advance, I mean, to have in your hand the molecular information can give you the opportunity of tailoring, probably in some specific situation that we have here this afternoon, and to make, you know, wiser decisions, you know, with all the details on your hand. So the sooner the better, if possible. I think that the future will come, you know, having in the hands in advance the data on this. Yeah, right.
Great.
Another point, Pedro, on this topic on preoperative biopsy, I think it is very important to highlight that if you can push your pathologist to inform the LBSI status, this is going to be crucial, because this is the variable most related with the sentinel lymph node involvement, and this is usually not informed in our reports. So, of course, if you are performing a curettage, it's not easy, but if you are performing a biopsy through hysteroscopy and you have the enough amount of tissue, they could inform this LBSI status, and this is another important point for me.
And Kike, I think that we have to mention, and we have to excuse Felix Boria for being so quiet. He still performs HIPEC, so he's just exhausted from completing a HIPEC procedure. So it's understandable. And thank you, Felix, for joining after those long and exhaustive HIPEC procedures. So with that, then we'll go to Italy, Susanna Del Frati.
Hello, thank you very much, and congratulations. Even if you have partially answered to this question in your amazing presentation, at the end, how might the results of the Seneca study influence the new ESGO endometrial cancer guidelines and lead to changes in the future practice?
Thank you, Susanna, for the question. Yes, as we said before, our findings show in more than 2,000 patients, this is very important, that there are two molecular groups, P53 and mismatch repair deficient, with a higher rate of nodal involvement. In addition, we have defined, as we have said several times today, the rate of sentinel lymph node involvement for each of the prognostic risk group. We believe that all this data will be very useful in the near future to guide the surgical tailoring of these patients. However, and this is very crucial, I learned that during my fellow with Pedro, it should not be forgotten that for this study is a retrospective study and should therefore be considered as a hypothesis-generating study to stimulate international collaboration as the Eugenie trial. Finally, regarding the ESGO guidelines, I think that the prognostic risk classification does not perform very well, this is another message, in predicting the nodal involvement as seen in our study, and maybe should be changed I know from Professor Antonio Gonzalez, the ESGO will soon redefine these prognostic risk groups, taking not only into account the molecular classification, but also the classical risk factors. Of course, I encourage you all to see what is the impact in our practice of these new ESGO guidelines.
All right, Kike, and then we have one additional question from your new recently met friend in Malaga, Dr. Clara Santilla from Argentina, who now is at Houston Methodist, and she's asking, does the fact that the poly group was smaller have to do with the fact that the majority of patients are stage 1 low to intermediate risk, and therefore those patients likely did not undergo poly testing?
Yes, thank you, Clara. I thought we were friends, but right now I am aware that no. So yes, if you take a look on our tables, there is 43% of patients that has the poly ultramutated analysis. If we consider to take the whole analysis to the whole cohort, if we were able to have that, maybe the proportion of positive sentinel lymph node of poly ultramutated would be slightly lower, because we have to add these patients at low risk and intermediate risk. So maybe if we have the complete analysis of the complete cohort, maybe the final amount of positive sentinel lymph nodes would be lower than 6%. Yes.
Well, Kike, thank you so much. I want to just, first of all, congratulate you. And I wanted to ask you one last question. From this large database, the Seneca database, are you working on any additional studies now from this database?
Yes, thank you, Pedro. Yes, we are working a lot. We are very lucky to have our chairman, Professor Luis Chiva, who pushed us to continue researching. And the main goal is to achieve the results in terms of survival. This is going to be called the Seneca relapse study. We are awaiting to the beginning of 2025 year, because at that point we would have 3 years from the first patient that was recruited. And then we are very lucky to have Felix Boria, who is pushing a lot. And maybe Felix, you could add your main field of researching with our cohort.
Yeah, we are working on 2 projects. The one about the sentinel lymph node mapping and factors associated with unsuccessfully bilateral lymph node mapping. And we are also working on the quality indicators on sentinel lymph node mapping.
And just the last
hopefully...
one. Yes.
No, continue.
And just the last one, we are pushing one of our residents to develop her PhD on imaging in our cohort, because I think there is a gap of knowledge with regard to molecular profile and how these tumors are represented in the imaging. So we are just exploring this field also.
Well, fantastic. Thank you so much, Kike. Again, obviously, great presentation, fantastic discussion. I want to thank all of the fellows who joined. It's so great to see many of the former fellows, and of course, obviously, also congratulate all of the collaborators on this study for submitting this manuscript to our journal. Thanks to all the fellows now who submitted some really great questions. So we're looking forward to the future journal club that will be in October. And this journal club is titled Oncologic Outcomes Based on Lymphovascular Space Invasion in Node-Negative Stage 1 Endometrial Cancer Patients. This is a multi-center study led by the group by Memorial Sloan Kettering. So we're really excited to have that as our next journal club. So with that, once again, congratulations, and Kike, fantastic job as always. We look forward to your next contributions.
Thank you, Pedro. It was my pleasure.
All right. Great to see you all.
Thank you.